wanted to have the PAs and the NPs and RNs to be able to talk. And so far we've been able to achieve that for the most part. We even have an MA. Oh my God, an MA speaking to us later in the morning. Can you believe that we would go down that far? Okay. This is designed to be an ecumenical organization of just people who deal with allergy. And while we start with the basis of Aspire personnel, because we knew they were going to be here for a meeting, this is an independent organization that has a board of directors and its own set of guidelines, which I have just been notified that I had violated for a moment ago because I gave a drug name, which nobody should report me for. I should know better than that, but I didn't. So it's been a pleasure to meet and talk with all of you. But we're going to be short because we have a real treat coming up with you with Amy Harrison. I don't want to cut into her time. Okay, we're going to talk about eosinophilic. Look, Dr. Lanier is a practicing dyslexic. So this is why Haley wanted to see my slides first to correct the spellings, but she didn't get this one, obviously. Did you? But you didn't tell me. Okay, thank you very much. All right, so you've seen this enough to have to worry about it. So we're going to do a little bit about basic immunology now, and really kind of how you react with your GIs, because that's a pretty crucial situation. So what is eosinophilic esophagitis? Is it caused by eosinophils? Is it caused? What do you think? You think it's a food allergy reaction? How about an autoimmunity? Okay, take the first one. What do you think it's just caused by eosinophils? Eosinophilic esophagitis is not caused by eosinophils? You do. Okay, he's just trying to play with me. He's trying to get even with me for yesterday. Okay. Food allergy reaction. Seems like it ought to be there, shouldn't it? I mean, you know, you got it in the esophagus, you're eating food. Of course, you're also draining down, stuff from the material. Is it basically an autoimmune disease of the esophagitis? Well, we don't really know. I mean, this is under evaluation from day to day. Nobody knows exactly what it is. The marker we know, but whether or not the eosinophil caused it is an issue. It hasn't been too long ago that I attended debates in the academy and college about whether an eosinophil was good or not. You remember that, George? I mean, there was people that said, no, eosinophils are good. They clean up immunologic degree. And then people said, no, they're bad. And it went back and forth for a while, and then people kind of came to a conclusion, no, eosinophils are negative cells where they're found. But this is the interesting thing that I want you to try to remember. There is a correlation and a spin on EoE between allergy, the genetics, and reflux. Now, that is an important thing because you will find some people that have eosinophilic esophagitis not to have allergy, and some people with tremendous allergy not to have this. So we don't really know, but when you see that little spinning diagram there, I want you to remember this is a threefold deal. Now, what it looks like, easy. It's the eosinophilic materials. It's greater than usually somewhere between 15 and 45 per high-powered field. This was pioneered in discussion by pediatric gastroenterologists, not adult gastroenterologists. They're later. The pediatric gastroenterologist started biopsying kids with reflux. And they said, look, they're eosinophils. And for a long time, the adult GI guys said, no, this is not an allergy. And over a period of time, they started doing it too, and sure enough, there it is. But it started with children and reflux, and it has been here since the beginning of time, but it's beginning to be a little bit more obvious now. So the comparison that we see between people here. Children have failure to thrive, vomiting, reflux, abdominal pain. Adults have all those. They also have more significant problems with impaction. I'm going to show you a couple people that I've dealt with through the years that have had this issue. First of all, Jonathan Spergel from I think University of Pennsylvania, but I may not be right there. Did the first blow here for food allergy, and said if you find the right food by skin pick or patch testing, we haven't discussed any of that today. Does anybody do patch testing here for food? Yeah, you would. Harvey? Oh no, Harvey's not here. We don't know what he does. I think he does ocular challenge for food, but I'm not probably there. Okay. But Jonathan is an interesting guy because he thought that this is all food-based and could take it away by identifying the foods. 77% of his patients. Plus, he's the one that came up with the magic 6-food torture diet that we used to use, I used to just say to people, hey, what do you like? Don't do that. So, when we identified something that people like, we stopped it. But this hasn't proven to be true over a period of time. Then Paul Dowling did a review a couple of years ago talking about the role of environmental allergy, tree, grass, weed, because almost all of them have it, or at least they have the possibility. So if you treat the environmental allergy, can you reduce or eliminate the eosinophilic esophagitis? He was of the opinion that while the pathogenesis is multifactorial, that regular old garden variety allergy had something to do with it. So here's the pathogenesis that we think about. And up here in the in the left-hand corner, an allergic insult with gastroenteritis, genetic risk factor, you begin to see the possibility of this barrier function in the esophagus skin to break down. And there are lots of immunology here that has targets. You'll only see a couple now targets that are there with approved drugs, but everybody is looking at their drug to look at for eosinophilic esophagitis. So what you know this today ain't what it's going to be a year or two from now. Richard's going to go over that with us. Here's a couple of people that have driven me crazy through the years. This gentleman had a high GE. He had obviously positive skin test, had elk milk and eggs and Bermuda grass. I vaccinated him and was unable to improve him. He has had to date esophagus that looks like this, where you see these longitudinal furrows, these rings, the narrowing, and somebody yesterday said that this was eosinophilic debris. I think most of the time that's candidiasis, but I won't be able to say an individual person. But you see these things, and when you see this, you know you're in trouble. So I spent half my life trying to prevent kids from developing this, because we thought if we get them early enough and treat them hard, that maybe we'll begin to see that we can prevent this disastrous disease later on. This gentleman that had this has been dilated now 18 times. And there's a limit to the number of times that you can stretch scar tissue, because at some point, dilation is going to be ruptured. And there just isn't much to replace an esophagus right now. We've looked at everything we can, including trying to get ready for that thing when it happens. But he is non-responsive to all attempts, allergy, monoclonal antibodies, treatment. He's just one of those people that just doesn't fit into a category that's very treatable. This is a child that I picked up 5 years ago because he had obvious gastroesophageal reflux. He also I looked at him and thought, holy moly, he's going to be one. That's going to be the guy. He had, as you can tell here from his prick skin testing. He had large reactions. He had a little bit of pecan, but almost no other food reactivity. And so it started him on a very strong program of PPIs and allergy vaccination. And 6 years later now, he's not developed any more, which I hope will be good enough. I've not put him on a monoclonal antibody yet. His mother's not quite sure she wants to do that. But that's the guy that I'm interested in, and you ought to be interested in, is a 4 to 8 year old kid with gross allergy and the real seeds for what is going to could turn out to be an adult disaster. So, a couple of practical questions. If you refer to GI, you've got somebody that you think has had the signal signs in addition to reflux, and you decide that you want to get a GI for a formal opinion. Here's what they're going to want from you. They're going to want you, and just go ahead and prepare it. They're going to ask for it. Prepare a note that has test results, including the food, the fact that you've manipulated or tried to manipulate the diet and the environment, and that you've had them on a PPI, maybe even Singular or Xyluten. Why would you use Xyluten, or as you call it, Zulutron, Dr. Harvey?
Well, I wouldn't use it for this.
Oh, you wouldn't use it for that? Would you use Singular?
No.
Even though it reduces the eosinophilia?
Well,
You didn't know that, huh? Significantly.
basically, I like budesonide slurries and pretty much for starters for kids.
Yeah, but you wouldn't do that before you had a diagnosis.
Before I got a jack, I want to have a tissue diagnosis.
Yeah. So that's what I'm saying. This is what you do before. And the question is, would you also do PPIs before? The answer to that for me is yes. You betcha. Because you get 35% or more that respond just to PPIs. Why? If it's a basic autoimmune disease, or if it's a big problem. Well, the reason is that the eosinophilic response is there. I mean, that's the response to injury. And when you reflux a lot, you're a setup for it. So you got that little spinning thing up there that says that there's a genetic component, there's an allergy component, and there's a reflux component. Now, the reason I put up Singular is because Singular does decrease peripheral eosinophilia. That's why Singular was marketed in Europe as an anti-inflammatory, but not in this country, because the FDA did not accept suppression of peripheral eosinophilia as indication of anti-inflammatory activities. Yes, Kurt?
You mentioned doing the PPI before referring because they respond. How are you defining response? Pathologic?
Just the symptoms that people are having with reflux. Yeah. I don't want to know yet, because I know 35% of them are going to respond just to a PPI. So, when I cut to the chase there. Now, I wouldn't do steroids, and I wouldn't do, more significant things before referring. But yeah, I'll do PPIs. I don't really use Singular because it's never been shown to decreasing the peripheral eosinophilia. It's never been shown to affect EoE yet, which brings into question some of the monoclonal antibodies we're talking about. Okay, now what's about the other option? I would say don't do this until the GI is seen. And that's fluticasone, vinacilide slurries, or any of the other materials. I'd say probably ought to wait, because that can change the biopsy material that they're going to do. And if you're going to go that far, you want to make sure that you got some baselines on it. So that I probably wouldn't do. Now, I would do the PPIs first, because I know that people are going to respond in certain realms to them. Now, do you do a monoclonal antibody? Well, if you do MEPO, which is an anti-IL-5, you'll see a reduction in eosinophils. Before I go any further, does everybody remember the Silence of the Lambs? I'm apparently showing my age here, and that I asked a patient the other day about, I told her that I was going to explain her you know, like from Desi and Lucy, you know. I'm going to explain you. Blank. Blank. I said, you don't know Desi or Lucy? No? Okay, so I was going to, because I got a thing coming up here in a second, and I was going to make sure that somebody had heard. If that's the marker for me, turn it off, because I'm not through. Okay, so I'm almost through, but I had to set this up right first. So you remember Anthony Hawkins from The Silence of the Lambs? Sure you do. Yeah, Cannibal, yeah, you remember that. Okay, so Mepo reduces eosinophilia. Dupilumab, that actually increases eosinophilia a little bit. Eosinophilic esophagitis increases eosinophils, but not eosinophil tracking. All right, so there's another mechanism here. Or you can use benralizumab, which shows an anti-eosinophilic antibody. And what you do is that puts a marker into the eosinophil, and that marker calls in the killers. All right. You got it, okay. When you have to explain it in advance, it just hurts. Okay, so if the GI refers to you, he's going to expect you to do testing, food manipulation, environmental. Teaching is something I've found that GI people don't do well. Well, I mean, I hate to expand that to a group, but they just don't, you know, I'm in there explaining why you shouldn't drink coffee and how you should have your head up, and they've never heard that before. And I say, really? Okay, so you're in the teaching business, and you're going to have to teach about GERD if they see you. And what they're looking for, of course, is when they refer to you, is the provision of some magic bullet like dupilumab. So we're going to see in the future what else is there, but remember, it involves eosinophils, but it's more than that. You know, it's a combination of genetics and issues of injury. So, Richard's going to tell us what's in the future.